All right, hello everyone, back with another presentation. Today will be investigations of jaundice. Quick review on secretions of the liver. So the liver creates and secretes bile through the gallbladder and the bile duct and stuff. What is the function of bile? It's mainly to neutralize all that acidic stuff coming in from the stomach into the duodenum, and as well as emulsifying fats. Now, what's important here is what's in the bile. So you got these 5 things. Main thing we'll be focusing on today is bilirubin. Okay, looks like a complicated diagram, but we're going to walk through it. So this is how bilirubin is produced and how it's processed in the body. A bunch of this isn't actually that important, so I'll talk about what is. We're starting here on the left-hand side with red blood cells produced in the bone marrow and stuff, and they have a lifespan of 120 days or 4 months. After 4 months, they die and they are phagocytosed, by macrophages. When they're phagocytosed, they're broken down into their elements, and heme, which is hemoglobin or heme and globin. Not that important. Globin is protein, heme is iron, and they're recycled through their own processes, as well as biliverdin. Biliverdin is a pigment. It has this green sort of color to it, which is why it gives the gallbladder its classic greenish look. Now, biliverdin is turned into bilirubin. Now, bilirubin we'll talk about a lot, but what's important about bilirubin before the liver is it's unconjugated. So unconjugated bilirubin will then travel and go into the liver where it's conjugated. Another important thing to note about unconjugated bilirubin is it is not water soluble. Okay, it's not water soluble. In the liver, unconjugated bilirubin is conjugated and it is released into the small intestine with the rest of the bile. If you want to quiz yourself, what part of the small intestine is bile released into? That's a good question. And once it's in the small intestine, it is then bilirubin, now it's conjugated bilirubin, is then processed by bacteria, where it is turned into urobilinogen, however you say that. And then it's sort of takes 2 pathways to be excreted out of the body. It either goes and gets excreted out of the kidney in the urine, where it's turned into urobilin, or it remains in the large intestine and it turns into stercobilin. Stercobilin gives feces its classic brownish appearance. So you can think of what would happen if you didn't have that. Okay, this is pretty much an outline. I think I've talked through all of this. Yeah, and the colors. Colors are not that important, but yeah. Greenish in the gallbladder, orange, yellowish in the blood and stuff, and then brown at the end for stercobilin, or yellow for urobilin. Moving on to jaundice. Okay, jaundice, what is it? It is pretty much yellowing of the skin and the sclera. So you first see it in the sclera around the eyes. And in some people, that's the only place you'll see it because of skin color and all these. It takes quite a bit of time and you need a lot of bilirubin in the bloodstream for you to see it in the skin, but you should be able to see it in the sclera of the eyes. What causes it is excessive bilirubin in the blood. Now, as we saw, bilirubin goes through all these different processes, and so different buildups of different bilirubin at different points in that process will present somewhat differently, and of course, management will be different. So the 3 main categories: prehepatic, intrahepatic, posthepatic. Hepatic meaning liver, and yeah. Okay, quick anatomy revision. You got the liver, big liver here in the right upper quadrant. Sitting underneath that is the gallbladder, where the bile sort of collects, common bile duct emptying into the second part of the duodenum at the ampulla of Vater. So that's where it enters into the small intestine. So as you can imagine, bilirubin, actually we'll come back to that later. Okay, prehepatic jaundice. Prehepatic jaundice. So this is happening, if you look at this diagram, before the liver. So before the liver, first of all, bilirubin only gets conjugated in the liver. So before the liver, it's unconjugated bilirubin. How is there going to be an excess of unconjugated bilirubin? It's mainly by this process here. So if there's increased breakdown of red blood cells, increased hemolysis of red blood cells, there's going to be increased byproducts, and thus there's going to be increased unconjugated bilirubin. Now, as you can imagine, the liver sort of has a cap as to how much bilirubin it can process at a time. So it's still conjugating some of that bilirubin, but there's too much for it to handle. So there'll be a buildup of unconjugated bilirubin, which will leak out into the blood while there's still conjugated bilirubin after, because the liver is fine. The liver is still working fine. How's this going to present clinically? You're obviously going to have jaundice. You have an increase in unconjugated bilirubin in the blood because it's prehepatic. Now, remember how I said unconjugated bilirubin is not water soluble. So you've got all this unconjugated bilirubin in the blood, and it's going to go through the kidneys, but it's not water soluble, so it's not going to be excreted in the urine. So your urine will look normal. And if we look at the stool, there's still conjugated bilirubin being made, and so there's still going to be stercobilin, and your stool color is going to be normal. Sweet. Moving on. No. Intrahepatic jaundice. So intrahepatic, inside the liver, there's some problem happening within the liver. What can cause liver damage? Alcohol, alcoholic cirrhosis, hepatitis, which is like viral causes, any sort of liver disease will cause the liver, the cells of the liver to sort of break down, and that would cause conjugated bilirubin to then leak into the bloodstream. Now, that would result in an increase in conjugated bilirubin, of course, but as liver damage then progresses, there would also be a decreased ability or capacity for the liver to conjugate bilirubin. So you'll have first an increase in conjugated bilirubin, and as the disease goes on, the liver function will decrease, and then you might also have an increase in unconjugated bilirubin as well later on. So we're going to focus on the conjugated pretty much. So you've got an increase in conjugated bilirubin in the blood. So you're going to obviously have jaundice. Now this increase in conjugated bilirubin will then go into the kidneys and as urobilin, and it's going to be excreted in the urine. Now, because there's excess, your urine will look darker. And since conjugated bilirubin is water soluble. Now keep in mind, there's still stercobilin being made, so your stools will be normal. They'll still have their normal color. And your liver enzymes, AST and ALT, will be released into the blood. So you'll see those elevated liver enzymes on liver function tests. Post-hepatic jaundice. Now, after the liver, what's happening is the bilirubin and the bile is being released. It's being stored in the gallbladder, and somewhere along that track, there's an obstruction, and that prevents the bilirubin from entering into the GIT. So this is where we'll go back to our anatomy. So here's your common bile duct, and anything that can sort of obstruct this will prevent the bilirubin, conjugated bilirubin, from being entered into the small intestine. And so it'll then start leaking out into the blood. So what can cause an obstruction here? Pretty much any pathology involving the bile duct, gallstones. Think of what's in close vicinity. So we've got the pancreas. So there's things, the like head of pancreas tumor can press on the bile duct and obstruct it. And that will result in post-hepatic jaundice. That backlog of the conjugated bilirubin will then go back into the liver, and it'll be released out into the bloodstream. Now, this is where it gets interesting because there's nothing being released into the small intestine. So all of these different processes aren't happening. So first of all, you have jaundice, of course, increased conjugated bilirubin only. And then what happens is, we'll walk through it. So in the small intestine, normally what would happen? Bilirubin to urobilinogen and then into urobilin. If this is cut off, your conjugated bilirubin is water soluble. So if there's an increase in conjugated bilirubin in the bloodstream and it enters into the kidneys, it's going to go into the urine. And so your urine will look darker. Now, coming back here, if there's no more bilirubin in the large intestine or in the GIT, there's no stercobilin being produced. So then your feces will look pale. So pale colored stools. These are the two biggest buzzwords for any sort of gallstone disease, any sort of head of pancreas cancer, cholecystitis: dark urine, pale colored stools. And then the liver enzymes might be normal. or slightly raised, but the main enzymes that are released are cholestatic enzymes, GGT and ALP. Okay, let's talk about those. So ALT and AST we talked about with intrahepatic jaundice. So anytime there's sort of liver damage, these are your liver enzymes, and they'll be increased because they're being released into the blood. Your biliary enzymes or your cholestatic enzymes are GGT and ALP, and they'll be released anytime there's something happening after the liver in the biliary tree. Now, specifically with these, with an ALT and AST increase, there's these ratios that honestly I didn't memorize much, so they're probably not that important. One thing I did remember is AST and ALT. So if AST is much greater than ALT, or stubbies over liver, that's alcoholic hepatitis. So AST stubbies is much greater than ALT liver. If they're equal, it's ischemia, and if ALT is bigger, then it's pretty much anything else, sort of hepatocellular damage. One exception to this is GGT, which sort of is indicative of excessive alcohol consumption, but it's not that sensitive of a test. Now, these are sort of measuring damage. So anytime something is damaged, these liver enzymes are released into the blood. But if we actually want to see how the liver is functioning, these are tests that measure the function of the liver. And what are they based on is the liver sort of produces a lot of these. So if we think of albumin and platelets, these are things that the liver produces. And so if there's liver damage and liver function is decreased, it's going to be producing less of these. Make sense? Bilirubin, on the other hand, what function does the liver play with bilirubin is mainly the transport and conjugation of bilirubin, because it's being created somewhere else. And so if it's not being transported and conjugated, it's going to leak out in the blood. So with decreased liver function, there'll be increase in bilirubin. Now, INR, something you talk about a lot in heme, but essentially it's not, it's a time. So it's the amount of time pretty much taken to clot blood. So the time taken to clot blood is dependent on how many clotting factors you have. If you have more clotting factors, blood's going to clot faster. If you have less clotting factors, blood's going to clot slower. And so if the liver and clotting factors are made in the liver. So if the liver function is decreased, there's less clotting factors being released into the blood. And so it takes more time to clot blood. And so your INR is increased. All in all, pretty much decrease in albumin, increase bilirubin, decrease in platelets, increase in INR. And if you're ever stuck, then you can think your way through it as to what function the liver plays with regards to all of these things. Okay, this is your final summary table with regards to jaundice. Prehepatic, intrahepatic, posthepatic. Let's talk through this real quick. Obviously, bilirubin is increased in all of them because they're presenting with jaundice. The only time unconjugated bilirubin is increased is in prehepatic because it's being conjugated in the liver. It can also obviously be increased in late stage intrahepatic jaundice. Whereas conjugated bilirubin is increased in intrahepatic and posthepatic jaundice. Now, in prehepatic jaundice, the liver is fine. The liver is functioning perfectly. The biliary tree is functioning perfectly. So all those enzymes should be normal. In intrahepatic, your ALT, AST, your liver enzymes are increased. In posthepatic, your biliary enzymes are significantly more increased. And this is what is tested sort of in like Flint skills and pretty buzzwordy is urine and stools. So each of these have different presentations for urine and stools. The main one you want to know is dark urine, pale stools. You're thinking posthepatic jaundice. You're thinking cholecystitis. You're thinking gallstones. You're thinking head of pancreas tumor, which are your main buzzwords. In prehepatic, they're both normal, and in intrahepatic, there's just dark urine. Stools are normal because there's still that stercobilin being made. All right, that's about it. I'll see you next week.